Hello, this is Dr. Steven Zuckerman, and I'm going to give a brief presentation on the different headache types, and this will be followed by a subsequent presentation in the management of these different headache types. So I was going to go over the different basic characteristics of the different headache types, and that's how we're going to evaluate them. The most common type that I see is going to be a migraine headache. Now these have a 3-to-1 female to male predilection, and one of the associated characteristics of a migraine, which can of course be light sensitivity, which is photophobia, or sound sensitivity, which is sonophobia. But the one that is most specific to migraine headaches is, in fact, nausea and vomiting. Some other interesting facts. Auras are not, in fact, very common, and they occur only in about 10 to 15% of migraine patients. The old theory that migraines were all of a vascular event with the prodrome or aura consisting of a vasoconstriction and secondarily a vasodilatation causing stretching and irritation of nerve endings. That hasn't been completely supplanted, but other theories such as this neuronal spreading depression have also been proven to be relevant. Again, nausea and vomiting are very common, and there is a certain headache type which happens only at a particular time in the menstrual cycle, which are menstrual headaches or catamenial headaches, and we'll talk about that a little bit more with treatments. Now, the men are not completely neglected in that they tend to get cluster headaches. Happens to be younger men. The headache tends to occur behind one eye and is associated with redness of the eye, a nasal discharge, maybe facial swelling, and the characteristic of the cluster is that one can have many headaches in a row, and they tend to occur between 2 a.m. and 6 a.m. and then go for a long time without the headaches. They can be extremely severe, and because of all of the above specific features, they're relatively recognizable. Another headache type is the so-called tension type headache, which does not have a lot of the specific features that migraines or cluster headaches have. They can be bilateral, associated with some neck tightness, felt as a vice or squeezing type sensation, and as opposed to migraines, which tend to occur more when someone tries to relax, the tension type headaches are a lot of times stress related. Now this is supposed to depict tension in some way. I don't really know how, but that's going to be a mnemonic aid to you to remember that. Not. One of the more common types of headaches that we see is actually analgesic abuse headache, which happens when patients, of course, take medications to get rid of their head pains, and if they do so with any frequency, they actually contribute to the development of more chronic headaches in a sort of withdrawal type of situation. And interestingly enough, the frequency of the different medications which can induce this analgesic abuse headache are relatively well defined. And so if one takes more than 5 butalbital containing pills per month, that can induce these analgesic headaches. Now, butalbital is a short-acting barbiturate found originally in Fiorinol than Fioricet, but there are many different variants of that kind of medication which do contain butalbital. Given this knowledge, clearly this medication should never be used. And in fact, the neurology societies say that this is a never to be used medication if at all possible. The misspelled opioids, up to 8 days a month. So if you're using them 2 days a week, you're going to cause a rebound or analgesic headache. The triptans, if you take them with too great of a frequency, can cause rebound headaches. And the NSAIDs as well, more than 10 to 15 days a month, can cause a rebound headache. So what happens is somebody will go from having episodic headaches to chronic daily headaches, or they could be called transformed migraine headaches. We also need to mention certain so-called red flags, i.e. some factors of headaches which would tend to make you a little bit more concerned that you're not dealing with a primary headache syndrome, but rather there's a potential for an underlying, somewhat serious cause of the headache. One of those factors could be people that are over 50 years old. I used to call those the elderly, but since now I'm 11 years past this age, I just think of them as 60 is the new middle age, which everybody knows because you see a lot of 120-year-old people running around. Of course, in that age group, we're considering the possibility of temporal arteritis, which will be unilateral, usually associated with tenderness over the superficial temporal artery, perhaps jaw claudication, perhaps polymyalgia rheumatica, or other systemic types of symptoms, with workup to include a sedimentation rate, and if there is consideration of this diagnosis, the initiation of high-dose steroids and proceeding to either a temporal artery biopsy, or there's also evidence that a temporal artery ultrasound is effective in helping to diagnose temporal arteritis. Another red flag would be the presence of fever, and of course that would trigger the consideration of an underlying meningitis. If somebody comes in with the worst headache of their life, particularly if it occurred during some exertion, the consideration there is for a subarachnoid hemorrhage due to a burst intracranial aneurysm. In that case, a prompt CT scan should be ordered, and of course, if that is negative, the next step would be to obtain a spinal tap, because there's only about an 85 to 90% sensitivity of a CT scan in detecting the blood of a subarachnoid hemorrhage. Immunocompromised patients, of course, are going to be at increased risk for meningitis. And finally, if there's abnormalities on the neurological examination, such as meningismus, papilledema, or focal deficits, further testing and investigation is recommended. And finally, the primary headache syndromes can be considered to exist on this sort of continuum, with migraine with aura on one end and muscle contraction or tension type headaches on the other. And now you know everything there is to know about headaches, except for its treatment, and we will go through that very shortly. Thank you very much.